All right, everybody, we are back for part 2, chapter 5. Key concepts are going to be listed again at the end. So, a rogues gallery of bad bugs. We're going to talk about some of the text ideas of some of the common pathogens that you will see in practice, talking about their unique virulence, pathogenesis, and vulnerability. Okay, so we start with a couple different bacterias. Remember, there is thousands of things we could talk about, a ton of conditions, a ton of diseases. So the text picked common pathogens and want us to kind of dive into that. This is not an exhaustive list. As you encounter different disease states or pathogens in clinical practice, you're going to have to look them up and read up on them. But we're going to hit some of these highlights. So the first one is Streptococcus pyogenes. It's the most common cause of bacterial pharyngitis, but it can also cause rheumatic heart disease, post-streptococcal glomerulonephritis, and cellulitis and necrotizing fasciitis. Okay. It is a form of group A beta hemolytic strep, often referred to as GAS. It also causes different skin affections. Obviously, strep throat is more common in children than adults, and also children are often asymptomatic carriers. Those that do have the active infection are most likely to transmit the pathogen via aerosolized droplets. All right, clinical presentation of what you might see with the disease of Streptococcus strep is you get often an abrupt onset of sore throat with fever, malaise, headache, and possibly GI upset in children. The GI upset is not nearly as common in adults. You could also have a diffuse rash known as scarlet fever that can occur after symptoms have started. And that's typically in those infected with certain endotoxin producing strains or suppurative complications such as a peritonsillar abscess. It can be skin and mucous membrane commensal, meaning common on to have it colonized. But it has pathogenic potential to cause superficial and systemic skin and skin infections such as impetigo, cellulitis, and necrotizing fasciitis. Necrotizing fasciitis is deadly, cellulitis can be deadly, and impetigo can be harder than heck to treat. Remember that an uncommon but devastating complication of group A beta hemolytic strep is streptococcal toxic shock syndrome, where you have the cytokine cascade can lead to shock, organ failure, and death. If untreated, your group A strep can provoke an autoimmune complication, which is where we get the rheumatic fever and glomerulonephritis. Rheumatic fever is the syndrome characterized by inflammation of the heart, joints, blood vessels, and the subcutaneous tissue. The worry about it is it causes damage to the cardiac valves and may cause cardiac decompensation and heart failure. Post-streptococcal glomerulonephritis is characterized by inflammatory attack against the renal glomeruli, leading to edema, hypertension, and potential hematuria and proteinuria. Okay, so if someone is got severe lower extremity, typically edema, and then you check a UA and they're hematuria and proteinuria positive, we need to consider glomerulonephritis, and that would trigger you to ask, have you had a recent strep throat infection? So Streptococcus pyogenes is a pathogen with a number of virulent factors. So it has that outer capsule that will assist with immune evasion, and it is able to invade our epithelial cells, which also provides protection from phagocytosis by neutrophils and macrophages, which is what we have here. So this is a schema of strep. The hyaluronic capsule assists with immune evasion, whereas the virulence factors include the M protein of the fimbriae or the pilia, lipoteichoic acid, and secreted substances that assist with this invasion, cellulitis, tissue damage, and fever. The fimbriae of the cell wall contain that M protein that binds fibrinogen and blocks complement fixation to the bacterial surface, which is the strategy of the immune evasion. The M protein here is one method of pathogen characterization. Strep also produces exotoxins, and among them are the streptolysin S, and that's capable of lysing red blood cells and tissue cells as the infection spreads. Group A strep infections are associated with high fevers due to pyrogenic factors secreted by the bacteria. So if you were to be asked by a mom, why does my kid always have 105 fever with strep? You could tell them, I'm really smart, I know this. It's due to the pyrogenic factors that are things secreted by the antigen, by the bacteria. We can often quickly diagnose strep because we have rapid antigen detection, and then we could confirm that with a throat culture. The good news is that strep remains susceptible to beta-lactam antibiotics, and so penicillin, specifically amoxicillin, is the drug of choice. Okay. So, clinical presentation of this. So now we are at a point where we are finally taking a disease such as Streptococcus pyogenes, group A strep. We've talked about its signs and symptoms, the complications of what happens to the body if you have that disease. Now we're going to talk about the clinical presentation to tie it together. So abrupt onset of the sore throat, fever, malaise, headache. In children, we can look at GI upset. Oftentimes, you have to remember to look for a rash. The scarlet fever is those infected with a certain endotoxin-producing strains, or if you think about people that have the complication of a peritonsillar abscess. It's not common, but we have to think about it, that the devastating complication is streptococcal toxic shock syndrome. You get a huge cytokine cascade, and that leads to pure organ failure and oftentimes death. I've added the link there, so let's jump over to osmosis and learn some more.
Streptococcus pyogenes, sometimes called strep pyogenes, can be broken down into strepto, which means chain, coccus, which refers to round shape, pyo, which means pus, and genes, which refers to forming. So strep pyogenes are round bacteria that grow in chains, and are responsible for a number of infections that often present with pus. Strep pyogenes are also called group A strep, or gas, in Lancefield classification, developed by American microbiologist Rebecca Lancefield. Alright, now strep pyogenes has a thick peptidoglycan cell wall, which takes in purple dye when gram-stained. So this is a gram-positive bacteria. It's non-motile and does not form spores. And it's also facultative anaerobe, meaning that it can survive in both aerobic and anaerobic environments. Finally, strep pyogenes is catalase negative, meaning it does not make an enzyme called catalase. However, unlike other common cocci like enterococci, strep pyogenes is pyrrolidonyl arylamidase positive, because it makes an enzyme called L-pyrrolidonyl arylamidase. To test for this, a small sample is taken from a suspected bacterial colony, and then inoculated to a disc pad that's embedded with pyrrolidonyl beta-naphthylamide. Another joy of a word. With strep pyogenes, pyrrolidonyl arylamidase hydrolyzes pyrrolidonyl beta-naphthylamide to produce beta-naphthylamide. Finally, another reagent called N-methylaminocinnamaldehyde is added to the disc, and it reacts with beta-naphthylamide, resulting in a bright red color that confirms strep pyogenes is pyrrolidonyl arylamidase positive. When cultivated on a medium called blood agar, strep pyogenes colonies cause beta hemolysis, also called complete hemolysis. That's because strep pyogenes makes toxins known as streptolysins, which hydrolyze the hemoglobin in red blood cells to transparent yellow color byproducts. But some other Streptococcus species, like Strep A galactii, are also beta hemolytic, so a bacitracin test is done to distinguish strep pyogenes. That's when a disc of bacitracin is added to the blood agar. Strep pyogenes is bacitracin sensitive, so the colonies die off, whereas with Strep A galactii, the colonies remain intact. Now, strep pyogenes has a number of virulence factors that are like assault weaponry that help it attack and destroy the host cells, and evade the immune system. So first, strep pyogenes is encapsulated, meaning it's covered by a polysaccharide layer called a capsule. And on the capsule, there are adherence proteins like lipoteichoic acid, streptococcus fibronectin binding protein, or SFBL for short, and M protein, which helps strep pyogenes attach to the host cells, like those in the skin or the pharyngeal mucosa. Then, strep pyogenes uses toxins like hyaluronidase, which destroys hyaluronic acid, a cement substance that keeps cells of the connective tissue and blood vessels tightly linked. Destruction of hyaluronic acid results in local inflammation and enables the bacteria to spread to the bloodstream. In the bloodstream, strep pyogenes uses streptolysin O and S, which are toxins that cause hemolysis, or red blood cell destruction. It also uses erythrogenic toxins, that are also called streptococcal pyrogenic exotoxins, or SPE for short, which come in 3 flavors, SPEA, SPEB, and SPEC. This leads to increased hemolysis in the dermal and submucosal blood capillaries. What's more, SPEA and SPEC are superantigens, meaning they don't need to be eaten up and processed by an antigen-presenting cell like a macrophage to generate an immune response from T cells. Instead, they interact immediately with the class II MHC molecule on the surface of the macrophage, forming a superantigen MHC complex, which then interacts with the T cell receptor and stimulates up to 30% of the entire T cell population. This is 300 times more powerful than the conventional antigens, and it stimulates the release of a whole bunch of inflammatory cytokines. Specifically, this is called a cytokine storm, and it can result in toxic shock syndrome, or TSS, which happens when a cytokine storm triggers widespread systemic vasodilation, making blood pressure drop, which leads to poor perfusion of vital organs. From the bloodstream, strep pyogenes bacteria can spread to other organs, like the lungs, causing pneumonia or lung abscesses, or the heart, where they form clumps called vegetations on the heart valves, causing infective endocarditis. Alternatively, if they spread to the central nervous system, they can cause brain abscesses or meningitis. Surprisingly, despite all that powerful arsenal, strep pyogenes can actually peacefully colonize the skin, the mucosa of the pharynx or throat, the vagina, and the rectum. It doesn't do any harm so long as the immune system keeps them in check, restricting their growth and preventing them from spreading somewhere else in the body. Problems arise in individuals with weaker immune systems, like infants and the elderly. Other immune-weakening conditions include HIV infection, diabetes, or a malignancy. In these cases, strep pyogenes usually gets in the bloodstream through a breach in the skin, a mucosal laceration, or following surgery. Most often, strep pyogenes causes strep pharyngitis, also called strep throat, which is the inflammation of the pharyngeal mucosa and tonsils. Strep pharyngitis might also be associated with scarlet fever, which is when intracapillary hemolysis results in bright red skin rash. When strep pyogenes infects the epidermis, it causes impetigo, which are superficial skin lesions that look like honey clusters. If the bacteria invades deeper, it can infect the upper dermis and superficial lymphatics, causing another skin infection called erysipelas. If it gets to the lower dermis, it's called cellulitis, which is an acute, painful, quick-spreading infection of the lower dermis and subcutaneous tissues. Sometimes the infection can spread even deeper, to the muscle fascia, causing necrotizing fasciitis, which is when the muscle fascia and subcutaneous tissue are destroyed in a process called necrosis. Finally, strep pyogenes can also cause post-infectious sequelae, which are complications that arise even after the bacteria has been eliminated from the body. For example, following strep pharyngitis, there might be acute rheumatic fever, or ARF for short. This complication arises because strep pyogenes has a bacterial M protein that mimics the structure of some proteins that make up the tissues in the body, like the myosin and glycogen of heart muscle and smooth muscle cells. This is not to say that they're identical, but rather that they're similar enough for the immune system to confuse these self-structures with the bacterial M protein, resulting in a type 2 sensitivity reaction. This means that the immune system releases a whole lot of IgG and IgM antibodies that are aimed to destroy the bacteria M proteins, but instead attack the heart muscle, causing myocarditis, the heart valves, causing infective endocarditis, or the pericardium, causing pericarditis. Another post-strep pyogenes complication is post-streptococcal glomerulonephritis, which means acute inflammation of the kidney's glomeruli, most commonly seen after impetigo. It typically occurs 2 to 4 weeks after the initial infection, because of a type 3 sensitivity reaction. This means that the streptococcal antigens that remain in the blood combine with antibodies to form antigen-antibody complexes that are deposited in the basement membrane of the glomerulus. This can activate the complement system and attract neutrophils to the glomeruli, resulting in kidney damage. Symptoms depend on the particular infection. With pharyngitis, there's fever, painful swallowing, and the tonsils look reddish, swollen, and there might be pus on them. With impetigo, there are itchy, honey-colored scabs on skin which can become fluid-filled blisters. With erysipelas, there are warm and painful lesions on the skin, with raised edges. With necrotizing fasciitis, there's fever, and the skin over the affected part becomes painful and purple-colored. With scarlet fever, there's fever, a bright red skin rash, and sometimes the tongue has a sandpaper feel. Finally, with acute rheumatic fever, there's a mnemonic for the symptoms, and that's Jones. J is for joints inflammation, O is for heart damage that causes new heart murmurs, N is for subcutaneous nodules typically seen on the elbows, knees, and the forearm. E is for erythema marginatum, a rash with thick red margins. And finally, S is for Sydenham's chorea, which is characterized by rapid involuntary movement of the face and hands. With post-streptococcal glomerulonephritis, there's mainly facial edema and dark red urine, because glomerular damage allows red blood cells to pass in the urine. Diagnosis of strep pharyngitis can be done with rapid strep test, or RST, which looks for bacterial antigens in a throat swab. However, since this bacteria can peacefully colonize people's pharynges, RST gives a lot of false positives, so a definitive diagnosis requires a culture from a throat swab. For skin infections, cultures can be done from the fluid inside blisters or from debrided tissues, and blood cultures can be done when a systemic infection is suspected. Ultimately, the treatment of strep pyogenes infections is penicillin, because unlike some other streptococcal species, which have developed penicillin resistance over time, strep pyogenes is still sensitive to good old penicillin G. For people who are allergic to penicillin, cephalosporins like ceftriaxone and macrolides like azithromycin might be used. Additionally, for necrotizing fasciitis, urgent tissue debridement is necessary. Alright, as a quick recap, Streptococcus pyogenes are gram-positive round bacteria that live in chains. They're non-motile, non-spore-forming, beta-hemolytic, and bacitracin sensitive. They colonize the pharynx, vagina, or the skin, where they're part of the normal flora, but in some cases they might take advantage of a weakened immune system and cause infections like strep pharyngitis, scarlet fever, impetigo, and necrotizing fasciitis. Post-infectious sequelae include acute rheumatic fever and post-streptococcal glomerulonephritis. Diagnosis might be done with a rapid strep test for throat infections, but a definitive diagnosis requires cultures from the affected site. Treatment can be done with penicillin G, and alternatives include cephalosporins like ceftriaxone and macrolides like azithromycin.
A great recap. We are going to pause here a moment, and I will move to the next one. The next one your book jumps into is Staphylococcus aureus. Let's jump right into osmosis. I've added the link up here. They have a great video as well. I can move my screen. Here we go.
Staphylococcus aureus, sometimes just called Staph aureus, is cockle or round shape and grows in clusters. In fact, its name, broken down, means golden cluster of grapes. It sort of starts making sense if you look at it under a microscope. It tends to grow in sticky clusters, and it stains purple when gram-stained due to its peptidoglycan cell wall, so it's gram-positive and it resembles grapes. As for its golden color, when it's grown on blood agar plates, the colonies have a distinctive golden yellow color. Staphylococcus aureus are gram-positive and facultative anaerobes, meaning that they can survive in aerobic and anaerobic environments. They're non-motile and don't form spores. Staphylococci produce an enzyme called catalase, which converts hydrogen peroxide to water and oxygen. Other common cocci, such as streptococci and enterococci, are catalase negative, so they don't have this ability, and we can use a few drops of hydrogen peroxide to differentiate them. Catalase positive bacteria will foam up, while with catalase negative bacteria, nothing happens. Now, a couple of other Staphylococci species, like Staph epidermidis and Staph saprophyticus, are also catalase positive. So to distinguish between them, we can look for another enzyme that's made by Staph aureus, called coagulase. Coagulase converts fibrinogen into fibrin. So let's say that we stir up some Staph aureus bacteria in a liquid emulsion, and then add a few drops of plasma which contains fibrinogen. The coagulase-positive Staph aureus will convert the soluble fibrinogen to sticky fibrin, which then visibly clumps up, whereas coagulase-negative bacteria won't. Staph aureus is extremely common, and about a quarter of the population is colonized by it, usually in their nostrils, groin, armpits, and other parts of their skin. But most of the time, it's a normal part of our skin flora, and doesn't cause trouble. The skin flora is a complex ecosystem of different bacterial species, and occasionally Staph aureus can start to dominate that ecosystem. In individuals that have Staph aureus colonization, a number of factors like the pH, humidity, sweat levels of the skin, as well as presence of other bacteria on our skin, all affect the amount of Staph aureus that's present. If more and more Staph aureus is around on the skin, it starts to penetrate through tiny microfissures in the skin, like you get with eczema, as well as larger breaks in the skin like you might get after shaving. In fact, it's particularly troublesome in terms of causing wound infections, where there's a large break in the skin either from trauma or after a surgery. So low levels of Staph aureus with intact skin leads to colonization, whereas high levels of Staph aureus with breaks in the skin leads to infections. When Staph aureus invades into the skin, it can lead to localized skin infections, like a pimple, which can evolve into a furuncle, or a boil. A bunch of furuncles clustered together make a carbuncle. There can also be diffuse skin infections, like superficial impetigo, which is an infection of the epidermis, or deeper-reaching cellulitis, which is an infection of the dermis and can spread over larger surfaces rapidly. If the infection goes deeper, it can develop into a subcutaneous abscess, which is a collection of pus that's walled off and sometimes develops thin walls within it, called septations. These abscesses can happen all over the body, including in the mouth, where they're called dental abscesses, and they can develop within various organs like the liver, kidney, spleen, and brain. Now, if the infection is overlying a muscle, it can spread into the muscle, causing pyomyositis. If it gets into the bone, it can cause osteomyelitis. And if it gets into the joint space, it can cause septic arthritis. Finally, if Staph aureus gets into the bloodstream, it can cause a septic thrombophlebitis, an infected blood clot. In addition, bacteria in the blood is called bacteremia, and it can lead to a number of serious problems. There's typically a widespread immune reaction that causes the blood vessels to expand and the blood pressure to fall. The result is hypotension and poor perfusion to various organs, a process called sepsis. Once it's in the blood, Staph aureus can also get to various parts of the body. It can get into the central nervous system, causing bacterial meningitis, or an epidural abscess in the spine. It can get into the lungs, causing severe pneumonia. It can start to grow in the heart valves in clumps called vegetations, damaging the valves, a process called infective endocarditis. Bits of the vegetations can then chip off and embolize further, causing other local infections around the body. Now, in addition to invading the body through the skin, Staph aureus can also enter directly into the bloodstream when a person is getting surgery or having dental work done. These events happen infrequently, but when they do come up, it's important to take precautions. For example, individuals at high risk of getting serious disease with Staph aureus, like immunocompromised individuals or those that are at risk for infective endocarditis, should be given antibiotic prophylaxis. Another property of our golden staph is its ability to create biofilm on medical implants like indwelling intravenous catheters, prosthetic heart valves, and artificial joints. The biofilm is essentially a layer of slime within which the Staph aureus live. It forms when a cluster of Staph aureus adheres to a surface, either a natural one like the surface of a valve or an artificial one like the surface of a catheter. The bacteria start to produce extracellular matrix made of exopolysaccharides, or EPS, and over time the cells get completely surrounded by it. The cells that are surrounded by the gel-like layer of exopolysaccharides can communicate with one another through biochemical signals, and can even swap genetic information back and forth, including antibiotic resistance genes. In addition, Staph aureus thrives but doesn't divide rapidly within these biofilms, and it's relatively hard for antibiotics to penetrate into the biofilms. Combined, that makes it a lot harder to get rid of these biofilm infections, and often requires simply removing the surface that they're growing on, if possible. If all this wasn't enough, Staph aureus can also release superantigens or toxins. In fact, there are 5 major toxins related to Staph aureus: toxic shock syndrome toxin 1, or TSST1, pantin-valentine leukocidin toxin, hemolysin, exfoliatin, and enterotoxin. TSST1 is produced at the site of infection and can enter the bloodstream. TSST1 binds to major histocompatibility complex type 2, or MHC2, which is a receptor found on immune cells called antigen-presenting cells. When TSST1 binds to the MHC class II receptors on these cells, it really stimulates them, making them release loads of pro-inflammatory chemicals called cytokines, creating a cytokine storm. The cytokine storm results in a number of physiologic changes, like fevers, a sunburn-like rash, low blood pressure, and poor end organ perfusion that can result in death. And together this is called toxic shock syndrome. Pantin-valentine leukocidin toxin, or PVL, punches holes in leukocytes, our immune cells, which kills them, and gives the toxin its name. Leukocytes with holes in their cell membrane die through necrosis, and that triggers inflammation. When that happens throughout the tissue, like in a necrotizing pneumonia, large chunks of the tissue starts to die off, and the organ can't do its job properly, and this leads to organ failure. Hemolysin is another pore-forming toxin that destroys erythrocytes, or red blood cells, releasing their hemoglobin, which contains iron, into the blood. Staph aureus uses iron in its own metabolism, so this is one way it gets access to that coveted heavy metal. Exfoliatin toxin causes staphylococcal scalded skin syndrome, or SSSS, or Ritter's disease. It creates painful patches of red skin, with fluid-filled blisters, but it often resolves within a few weeks. Finally, there's enterotoxin. Staph aureus might land on food and start to generate enterotoxin. The enterotoxin is quite stable in the environment, and can remain active even after the bacteria are killed off by cooking. The toxin can even withstand boiling at 100 degrees Celsius for a few minutes. If the toxin is eaten, it can cause food poisoning, with symptoms like vomiting and diarrhea a few hours after ingestion. And in rare situations, if the enterotoxin somehow gets into the bloodstream, it can cause toxic shock syndrome, much like TSST1. The main treatment for infections is antibiotics, but Staph aureus adapts quickly and has developed resistance to a number of antibiotics. Penicillins, which are beta-lactam antibiotics, were tried early on. They work by disrupting the enzyme DD transpeptidase, which is a penicillin binding protein, or PBP. PBP is in charge of cross-linking the long strands of aminopolysaccharides that make the peptidoglycan cell wall, running in parallel. These are made of segments of N-acetylglucosamine, or NAG, and N-acetylmuramic acid, or NAM, in an alternating pattern, so NAG, NAM, NAG, NAM, and so on, like a pearl necklace. Protruding from the tips of the NAM subunits are tetrapeptide and pentapeptide chains. These peptide chains can link to other peptide chains from the neighboring strands through a process known as transpeptidation. If PBPs aren't allowed to work, no peptidoglycan is made, and the cell wall becomes leaky. So when the bacteria try to divide and make more cell wall, they simply can't, and they die. Nowadays, though, practically all strains of Staph aureus make beta-lactamases, which allow them to simply disable beta-lactam antibiotics by breaking down their beta-lactam ring. Next, antibiotics called beta-lactamase inhibitors, like clavulanic acid, were used to bind and disable the beta-lactamases. In addition, new types of beta-lactam antibiotics, like methicillin, were identified that couldn't be easily destroyed by the beta-lactamases. Unfortunately, some Staph aureus strains found a way around this as well, by evolving and expressing a gene called MEK-A, which encodes special PBPs that are unaffected by beta-lactam antibiotics. Methicillin and older penicillins can't physically fit into them, rendering them ineffective. These methicillin-resistant Staph aureus strains are called MRSA for short, and have become more common around the world. There are two major categories of MRSA: the healthcare-associated MRSA, or HA MRSA, and community-associated MRSA, or CA MRSA. HA MRSA is found in places like hospitals and nursing homes, where there are lots of chronically ill patients with a high usage of antibiotics. CA MRSA is found in the community, and is thought to be due to rampant antibiotic use on factory farms, and overprescription of antibiotics. Both HA MRSA and CA MRSA pose a major problem, because infections with those strains cannot be treated with beta-lactam antibiotics. As a result, another class of antibiotics, glycopeptide antibiotics, like vancomycin, are often used instead. Unfortunately, it's not as effective and comes with problematic side effects. To make matters worse, some Staph aureus strains have developed intermediate resistance to vancomycin, and they're called vancomycin intermediate Staph aureus, or VISA for short, which is not the type of VISA anyone wants to get. The strains with complete resistance are called vancomycin-resistant Staph aureus, or VRSA. The search is on for new antibiotics and vaccines to prevent Staph aureus infections, but the overuse of antibiotics makes rapid resistance an ongoing problem. Ultimately, treatment of Staph aureus infections involves testing the bacteria against a handful of antibiotics and then choosing the most appropriate antibiotic from them. Sometimes hospitals put together an antibiogram, which shows how frequently bacteria are resistant to a particular antibiotic. Typically, when treating MRSA, antibiotics like clindamycin or vancomycin are chosen, but alternatives like tetracyclines, trimethoprim or sulfamethoxazole, linezolid, tigecycline, daptomycin, and quinopristin dalfopristin. Alright, as a quick recap, Staph aureus is a gram-positive coccus that grows in clusters. It's a part of the normal skin and nasal flora in about a quarter of the population, but if it overgrows or if the skin is damaged, then it can cause disease through direct colonization, toxin production, or both. Staph aureus is very adaptive, and it's become resistant to various antibiotics. Methicillin-resistant strains are often classified as HA MRSA or CA MRSA, and vancomycin intermediate and vancomycin-resistant strains are called VISA and VRSA.
I am going to watch the next topic on here because I feel it's very important, and I'm sad that your text chose to leave out Staphylococcus epidermidis. It is different than Staph aureus, and it is a very, very, very common thing. It also is a very common contaminant, so you do see Staphylococcus epidermidis come across quite a bit in practice. So I'm going to have us watch that.
Staphylococcus epidermidis, or simply Staph epidermidis, can be broken down into staph, which means grapes, coccus, which means round shape, and epidermidis, referring to the superficial layer of the skin. So, Staphylococcus epidermidis are round bacteria that tend to live clustered together as if they were grapes. And they are part of the normal skin flora, even though they may also be found living in the mucosa of the gut. Now, let's start with a little bit of microbe anatomy and physiology. Staph epidermidis has a thick peptidoglycan cell wall, which takes in purple dye when gram-stained, so this is a gram-positive bacteria. It's non-motile and doesn't form spores, and also it's a facultative anaerobe, meaning that it can survive in both aerobic and anaerobic environments. Staph epidermidis is catalase positive, so it makes an enzyme called catalase. We can use this to differentiate staph epidermidis from other gram-positive cocci, like streptococci and enterococci, which are catalase negative. To test for this, a few drops of hydrogen peroxide are added to the colony of the suspected bacteria. So, if catalase is present, like in staph epidermidis, it makes the hydrogen peroxide dissociate into water and oxygen, causing the mixture to foam. Staph epidermidis is also urease positive, meaning it produces an enzyme called urease that dissociates urea into carbon dioxide and ammonia. This can be tested by transferring a pure sample of bacteria from the culture to a sterile tube containing a mixture of urea agar broth and phenol red. Then, the mixture is incubated. So, with staph epidermidis, urease does what it does, making urea dissociate into carbon dioxide and ammonia. The ammonia then makes the mixture change color from orange-yellow to bright pink. This doesn't happen with urease-negative gram-positive cocci, like Streptococcus pneumoniae or Enterococcus faecalis. Furthermore, unlike many other Staphylococcus species, staph epidermidis and its close relative, staph saprophyticus, are both coagulase-negative, meaning they don't produce an enzyme called coagulase. Testing for coagulase is done by transferring a colony of the suspected bacteria in a test tube containing fibrinogen-rich plasma. Coagulase-positive bacteria, like Staph aureus, convert the soluble fibrinogen into sticky fibrin, which then visibly clumps up. With coagulase-negative species like staph epidermidis or staph saprophyticus, the fibrin doesn't clump up. Finally, to distinguish staph epidermidis from staph saprophyticus, the novobiocin test is done. This is when a disc imbued with novobiocin, an antibiotic, is added to the culture. Staph epidermidis is novobiocin sensitive, so the colonies will die off, whereas staph saprophyticus is novobiocin resistant, so the colonies remain intact. Alright, now staph epidermidis is actually the most dominant bacteria on the human skin. It colonizes mostly the scalp, the face, the nasal cavities, and the axillae, where it lives as an innocent commensal without causing any harm. And since it's the most abundant bacteria on the human skin, it is a common contaminant of blood cultures. Besides blood cultures, staph epidermidis can also contaminate indwelling medical devices, such as intravenous and urinary catheters, and prosthetic devices like prosthetic heart valves and prosthetic joints. Here, staph epidermidis can form adherent biofilms, which is basically a layer of slime made of exopolysaccharides, or EPS, within which staph epidermidis live and reproduce. Comparing a biofilm to strawberry jam, the seeds would be the bacteria, and the rest of the jam would be the EPS. Biofilms make it difficult for neutrophils and antibiotics to reach the bacteria, so the infection is more difficult to treat. Now, the clinical presentation of catheter-related infections is nonspecific, and it includes local and systemic signs and symptoms. Local signs and symptoms include pain, tenderness, swelling, warmth, erythema, and purulent discharge. Moreover, purulent discharge is actually a strong indicator of infection, but it's absent in many cases. On the other hand, systemic signs and symptoms include fever, headache, fatigues, and chills. Also, a person can complain about rigors and chills while receiving infusion. As far as complications go, bacteria can migrate along the intravenous catheter and enter the bloodstream, causing bacteremia or sepsis. Alright, now switching gears and moving on to prosthetic devices. Staph epidermidis is a major cause of prosthetic valve endocarditis, or PVE. Prosthetic valve endocarditis can occur due to direct intraoperative contamination or via hematogenous spread during the first several weeks after the surgery. Individuals with prosthetic valve endocarditis typically present with fever and valve dysfunction, and the diagnosis is confirmed by positive blood cultures and transesophageal echocardiography. Transesophageal echocardiography can detect small vegetations on the valve, which mostly consist of platelets, fibrin, and bacteria. Just like with the prosthetic valves, staph epidermidis can contaminate prosthetic joints at the time of surgery and cause prosthetic joint infections. Common signs and symptoms of prosthetic joint infections are typically nonspecific, and they include fever, pain, joint swelling, erythema, and warmth around the joint. A strong indicator of prosthetic joint infections is the presence of a sinus tract communicating with the prosthesis. Treatment of staph epidermidis infections is typically done with vancomycin, but if the bacteria is methicillin-sensitive, staph epidermidis can also be treated with oxacillin or nafcillin. Infected medical devices should also be removed. Alright, as a quick recap. Staphylococcus epidermidis is a round, gram-positive, facultative anaerobic, non-motile, non-spore-forming, catalase-positive, coagulase-negative, urease-positive, and novobiocin-sensitive bacteria. It grows in clusters, and it's the dominant bacteria of the normal skin flora. Therefore, it is a common contaminant of blood cultures. but it's best known to contaminate and make biofilms on indwelling medical devices, such as intravenous and urinary catheters and prosthetic devices, like prosthetic heart valves and prosthetic joints. Treatment relies on antibiotics like vancomycin, and removing and replacing the infected medical device with a new, clean one.
I do think that that's an important one to talk about and to remember because you're going to see Staphylococcus epidermidis quite a bit as well. Going back, these are the things that your book kind of reflects upon for the Staph aureus. When you think skin infections, we think abscesses, boils, those kind of things, cellulitis. But then we also have to think of endocarditis, septic arthritis, osteomyelitis. This is one of the ones that can be diagnosed with that NAAT. Here are some of the virulence factors that would be specific to Staph aureus. So if you were to be asked, what are some of the virulence factors of Staph aureus? These would be things you would want to say, that they produce several exotoxins. They have a beta-lactamase that degrades penicillin, so drugs can often be resistant to them. XYZ. This one here is a nice image as well. And this is from your book. Here too, I'm trying to find the same one I'm looking for. There it is. This is figure 5.9. This is Staphylococcus pathology. We have the Staphylococcus FNBPs that mediate the cellular attachment, whereas the secreted alpha toxin form pores in the host cells, ultimately destroying them. The CLFs contribute to aggregate formation, and fibrinogen conversion to fibrin is promoted, leading to a walling off process that can contribute to a boil formation. This is the Mycobacterium tuberculosis screen. I'm going to add the osmosis one here. That helps give the link. I'm not going to play this one here because otherwise this PowerPoint presentation is going to get really long, but hold on. So I do want you to go now and watch that osmosis video, then pause and come back here. It's a beautiful one, just like the staph ones that are really going to help illustrate for you what we're talking about. A couple of points that your book wants to talk about from Mycobacterium tuberculosa. Obviously, we're talking about TB, quote unquote. It's been one of the most feared diseases across the globe. It's most commonly related to being a pulmonary infection, but it can virtually affect every organ. And the terrifying part is it can persist lifelong in its human hosts. Today, TB affects about 1/3 of the human population, and when we look at worldwide deaths, it's in the top. It is the Mycobacterium tuberculosis is a non-motile, non-forming spore aerobic bacterium that is a thin, straight, or slightly curved rod under microscopy. Okay. Tuberculosis is not classified as gram-positive or gram-negative, but instead characterized by its acid fastness. Okay, so there is a difference between TB infection and TB disease, which is really important to know. Humans infected with TB never actually develop the TB disease. Rather, the organism is completely cleared through the immune response or is controlled as a latent infection. Primary tuberculosis is most likely found in young children. The risk of latent tuberculosis reactivation is highest in those who are immunosuppressed. Reinfection can also occur in individuals who are repeatedly exposed to the tuberculosis and may lead to disease development. Mycobacterium tuberculosis, MTB, are caused when you inhale infected particles called the droplet nuclei, and they spread via aerosols when a person with pulmonary tuberculosis has the disease, if they talk, cough, sneeze, or inhale those droplets. the infectiousness or bacterial load of the source patient, the closeness of your physical contact, and the frequency and duration of exposures all impact the risk of inoculation and the exposed individual getting the disease. Okay, so even though all those factors are at play, overall MTB is considered to only be moderately infectious, which is great because it's a horrible disease. When your bacteria of the MTB enter the respiratory tract, many of the bacilli will be trapped and removed by the airway mucociliary clearance, or our cough reflex. And we have some other immune protective mediators of our upper airways. But tubercle bacilli that escape these early defenses may actually penetrate to our alveoli. It's that deposition into the alveoli that triggers an influx of our pulmonary macrophages, which phagocytize and destroy some of the bacilli. Other tuberculous bacilli will begin to replicate within the alveolar macrophages, and that's when the TB infection begins. Infection may subsequently either progress to latent TB or, less commonly, active TB disease. Okay? Early spread of the MTB to the other lung areas and other tissues may occur via the lymphatics. So in addition to the lungs, the kidneys, the long bone, spine, and meninges, these are all sites where the organism can replicate. Over the next several weeks, the macrophages induce a cascade of additional immune mediators, such as our cytokines, tumor necrosis factor. And then they ultimately present the TB antigen to our T lymphocytes, and that initiates the adaptive immune response. The bacilli are able to evade complete eradication through several of our own protective mechanisms. Those include the secretion of our enzymes and antioxidants that allow survival despite macrophage ingestion. So the accumulation of the macrophages and T cells creates a granuloma that surrounds the tubercle bacilli. So this is the tuberculosis life cycle, okay? We get the airborne droplets coughed and inhaled. They make it past the primary kind of protection and get down to the alveoli. There, we get these infected macrophages. And those macrophages over several weeks induce the cascade of the additional immune mediators, right? So cytokines and tumor necrosis factor, and then ultimately present as a solid granuloma, right? So the granuloma contains infection, bacilli replicate, and immune cells will multiply. Although the granuloma serves to limit the bacterial replication and spread, it allows the bacteria to persist as a latent tuberculosis infection. So within the granuloma, the oxygen becomes depleted. This reduces the bacterial cell division rates, but it doesn't eradicate the bacteria. So they kind of become protective in the inside of this granuloma. The granuloma shell may break down over time, allowing those infectious particles to escape, to multiply, and then to ultimately lead to the active disease. And that's when the patient's going to have fever, night sweats, weakness, anorexia, and unintended weight loss, and then ultimately a cough. If someone is immunocompetent, our immune system is good, there's an average 10% lifetime risk of actually getting TB disease. The risk is higher within the first 1 to 2 years following the infection. Okay, so you can get the infection, you can have it inhaled, infected macrophages we get to here, but it can stay here latent for many people. If you have a good immune system, only 10% of people will develop TB within their entire lifetime, will actually have the disease with the symptoms. And the highest rate is in the first 1 to 2 years after you become infected. Immunocompromised patients, however, have a very heightened risk, especially, for example, if you have a co-infection with like uncontrolled HIV. Another risk factor includes the use of tumor necrosis factor inhibiting drugs for autoimmune diseases. So oftentimes people have to have a pretty good tuberculosis screening and workup before they can get these drugs. If they had a latent TB sitting in there and you get that drug, you're going to activate the TB. So again, if you were to say, how is tuberculosis infection, how does that happen? How does one get it? You have the droplets that contain the MTB bacilli. They're inhaled, they get deposited in our alveoli, and they are engulfed by these macrophages. The macrophage activation leads to the cytokine release. This attracts additional immune cells, including our T and B lymphocytes, which are our natural killer cells, and our neutrophils. Then we get the solid granuloma, which forms around that core of those infected macrophages, foam cells, giant cells, epithelioid macrophages, and dendritic cells. And that's all surrounded by lymphocytes, neutrophils, and our natural killer cells, and forms a granuloma. It becomes solid. Macrophage death leads to transition of the solid granuloma to a caseating granuloma with a liquefying center. And then from that stage, the granuloma may ultimately collapse and everything essentially gets spilled back out into circulation, and that's how someone has an active infection. So we know that a chest x-ray, wrong screen. A chest x-ray is often done, and that'll show these areas of infiltration and a cavity formation, and sometimes that's our first clue that someone can have TB. But then we do an AFB, which is an acid-fast bacilli smear microscopy, and it's recommended in all patients suspected of having pulmonary TB. The sputum AFB culture remains the gold standard for pulmonary type tuberculosis diagnosis. But the acid-fast bacilli culture has a slow division rate of the bacteria, and that can require extended incubation. So in a high-resource setting like America, the NAAT has become a mainstay for rapid diagnosis and identification of pharmacological susceptibility. Screening for latent TB can be done by the tuberculin skin testing, right, the PPD, or the interferon Y release assay. Okay. The establishment of a cell-mediated immunity marks the stage by which the tuberculin skin test will become positive. Alternatively, we can use the interferon Y release assays to measure the amount of the interferon released when the white blood cells isolated from the person being screened are then exposed to the TB antigen. This test has relatively strict requirements for correct performance, but has the advantage of being useful in patients who have previously received treatment with Bacillus calmette-guerin, BCG, as well as not requiring a follow-up appointment like the TST does, the PPD test does. TB treatments rely on the separate class of antibiotics that are able to penetrate cells and target the mycobacterium. Next in your book, we jump to the next big disease is chlamydia, a nice sexually transmitted infection. So I've added the Osmosis Elsevier link up here. Please stop here and listen to that first or at some point before we move on to the next topic. This is chlamydia, which is a very well-known sexually transmitted infection. It is an obligate intracellular bacterium with a gram-negative like cell wall. Okay, it is the most commonly reported sexual transmitted disease in the United States. I can't say that 5 times faster than that. Most common STI, chlamydia. When you think chlamydia, think the potential for pelvic inflammatory disease in women. We have to have the NAAT to be able to identify it now. Because of its small genome, the organism has a limited enzyme repertoire, and it relies on the host cell to provide the energy and aid in its multiplication. It has a biphasic life cycle, whereas the bacterium alternates between 2 forms that allow survival in both intracellular and extracellular environments. It's a smart little booger. In the extracellular environment, chlamydia exists as an infectious, spore-like elementary body that are able to withstand harsh environmental conditions as well as enter host cells. Within several hours of cellular entry, the elementary body converts into a non-infectious reticulate body that specializes in nutrient acquisition and replication via binary fission. So let's say that again. In the extracellular environment, chlamydia exists as infectious, spore-like elementary bodies that are able to withstand the harsh environmental conditions, as well as they can enter the host body. It will be converted into non-infectious reticulate body that specializes in nutrient acquisition and replication via binary fission. Okay. So we've got 12 hours and then into 24 hours. The reticulate bodies revert to elementary bodies in an asynchronous manner for release and spread, generally resulting in a carefully timed death of the host cells. Chlamydia targets the squamous and columnar epithelial cells of the endocervix and the upper genital tract of women, and it targets the urethra and rectum and conjunctivae of men and women. The attachment involves the interaction between the host receptor and numerous bacterial ligands, such as the heparin sulfate proteoglycans, etc. Damage to the epithelial cells induce the secretion of numerous pro-inflammatory chemokines and cytokines. The major outer membrane protein, the MOMP, and chlamydial heat shock proteins, among others, are involved in the immune response, but we don't really understand completely yet how that all works. In as many as 70% of primary genital tracts due to chlamydia, the immune response is sufficient to clear the pathogen. What does that tell us? We can be exposed to chlamydia a lot more than we're aware of, but our body takes care of it itself. In infected males, the chlamydial infection causes urethritis, but if left untreated, can lead to epididymitis and proctitis. In females, an initial infection can cause cervicitis, urethritis, and endometritis. If the infection progresses to the female upper genital tract, pelvic inflammatory disease can develop. Pelvic inflammatory disease is often shown as pain, tubal occlusion, and problems with infertility. Chlamydial infection has also now been associated with risk of cervical carcinoma. It is best to do a first catch urine for NAAT, vaginal or cervical swabs, or urethral swabs. It still is well treated by a course of doxycycline. Responds very well to it. All right, on the course of the STIs, let's jump over to gonorrhea. Jump over to osmosis. I've added the link and listen to the gonorrhea. It's a phenomenal one as well. Really, really helpful in us understanding gonorrhea. Again, it's a sexually transmitted infection. It can also cause PID in women, but it often is a co-infection with chlamydia. Diplococci with membrane-attached pili for the mucosal invasion and motility. It is Neisseria gonorrhea. The Neisseria organisms are gram-negative, non-motile, non-spore-forming bacteria that are often paired as diplococci. They can grow in aerobic or anaerobic conditions. It is important to note that there's other Neisseria species, so they also are similar to gonorrhea as well as meningitis. So gonorrhea is an obligate human pathogen. It most commonly infects our mucosal membranes of the GU tract, but also you can have gonorrhea of the eye, throat, and rectum. More specifically, the urethra and cervix are the most common initial infection sites in men and women, respectively. So men in the urethra, women in the cervix. The most common form of transmission is through sexual contact with an infected individual. It's a greater risk with vaginal intercourse rather than anal or oral intercourse. The risk of male to female transmission is higher than for transmission from female to male, possibly secondary to host anatomical differences. Remember, here's another form of vertical transmission that can occur from mother to child during delivery. Dissemination of the gonorrhea, so if it gets widespread, can lead to arthritis, endocarditis, and again, meningitis. The host-pathogen interaction at the epithelial surface is key to the pathogenesis of gonorrhea. Several structure components specifically contribute to its virulence. On the surface of the organism, specialized pili extend and retract to promote host attachment. You can see here. And on the surface of the organism, those pili form bacterial aggregation and provide a twitch-like motility. The opacity proteins also facilitate the tight attachment to the epithelial cells. Both structures, along with the lipooligosaccharides and the porin, promote colonization. So in that process, the bacteria likely compete with normal flora for the nutrients to support replication. Once colonization occurs, innate and adaptive immune responses attempt to counter the pathogen. The lipooligosaccharides, which have the endotoxin-like properties, contribute to the inhibition of neutrophils, cytokine activation, complement, and the host inflammatory response. If someone were to ask you how does gonorrhea present? For men, typically is the urethritis. Also for women can be the same. It happens typically in men. The urethritis comes on within 2 to 7 days after infection, and they get the purulent discharge from the urethra. The purulent discharge is thought to come from the combination of the neutrophil response and the epithelial cell shedding. We know that there's an incubation period that likely precedes the onset of symptoms, so there's a delay. The gonococci have been located within both neutrophils and urethral epithelial cells. It has been proposed that the urethral epithelial cells house and protect the bacteria during early infection. Then the subsequent release of the chemokines, cytokines, and tumor necrosis factor alpha from the epithelial cells then initiate an inflammatory response by triggering the neutrophil influx. So there's a cascade that would cause the clinical symptoms of the urethritis. In women, the initial exposure occurs at the cervix, so most commonly is cervicitis. However, in contrast to the significant inflammatory response that usually accompanies infection of the male urethra, up to 80% of the women with the lower genital tract infections are asymptomatic. That finding is further supported by studies that demonstrate a lack of antibody immune response to gonorrhea and cervical secretions. Invasion into the upper genital tract for females is through a combination of mechanisms, including the twitching motility, any additional virulence factors, and the organism's ability to exploit the hormonal changes of the genital tract. Adhesion to the ciliated cells of the fallopian tubes induce cellular shedding due to various cytotoxic effects. And remember, if left untreated, infection that ultimately advances to the upper genital tract can cause pelvic inflammatory disease. If you know and remember anything about PID, it's bad because it leads to infertility and ectopic pregnancies. Currently, the CDC recommends urine NAAT for both chlamydia and gonorrhea. Gonorrhea, though, is curable, which is good. Chlamydia can lay dormant. Okay. We covered two of the first and real big STIs, chlamydia and gonorrhea. Your book jumps right into another topic then of C. diff, Clostridioides difficile. So I've added Clostridium difficile osmosis link up here. Take a break now and let's go watch that. I'm not going to watch it on the video for the rest of this because I don't want this to get super long. Okay, the good old Clostridioides difficile. It's now Clostridioides instead of Clostridium. However, it is a gram-positive, rod-shaped anaerobic bacterium. Its ability to form spores allows the pathogen to survive in unfavorable environmental conditions that helps facilitate human-to-human transmission. That's why in the hospital now we have special wipes for C. diff, because we know the spores can live on surfaces for a long time, so you have to have the certain type of killer to clean a C. diff room. Although we know that there's many strains, colonization is more common than infection, as only the toxin-producing strains can actually cause the disease. We can have varying degrees of clinical severity. It can be mild diarrhea to straight-up pseudomembranous colitis. C. diff can be fatal, right? We know that. It can also lead to intestinal perforation, acute peritonitis, bad things. We now know that we can have community-acquired C. diff and nosocomial C. diff. CDI is the abbreviation for C. diff infection, and it's based on both a clinical and a laboratory finding for diagnosis. So you have to have the presence of diarrhea, which is 3 or more unformed stools in 24 consecutive hours, and a stool test positive for the presence of the toxigenic C. diff, its toxins, or a colonoscopy or histopathologic finding consistent with pseudomembranous colitis. It's really important because the diarrhea needs to be watery liquid. Okay, we can't have in between formed stools, persistent diarrhea, watery type stools. Sometimes it's just mucus, and sometimes it can even be occult blood. Typically with C. diff, you can get fever, cramping, and abdominal pain, but remember, you can get mild C. diff, so maybe they don't feel all that bad, they just have diarrhea. Leukocytosis may be present. Now we know that C. diff can happen in the hospital as a nosocomial infection. So now it should be in your differential. If you have a patient with a persistent leukocytosis in the hospital, you need to ask about their stools. We have a lot of different steps now to identify C. diff, and it can be very confusing whether or not you actually have active disease or not. The likelihood to get the infection, we know you're older if you've been in the hospital or if you've been treated with broad spectrum antibiotics or persistently long-term proton pump inhibitors like we know that the antibiotics can kill that normal flora, which is not a good thing because that normal flora was keeping our gut biome stable. When we kill off that flora, we allow for an override of this new bacteria like C. diff, and that is a problem. The ingestion of the spores by a vulnerable host can reactivate the pathogen. Bacterial proliferation accompanies exotoxin synthesis and secretion that targets gut mucosa. Our host inflammatory response then causes this widespread epithelial damage and can form the pseudomembrane formation. So this one here in your book, Figure 5.13, the presence of the normal microbiota of the gut and function tends to resist the transformation of C. diff colonization to infection and diarrhea. Okay, so the inhibition or loss of these mechanisms by a PPI can reduce the gastric acid secretion or changes in the microbiome due to aging or antibiotic use. That can be what can initiate the transition from the spore colonization state to the active expansion state of the C. diff bacteria, forming the infection and diarrhea. So in the stomach, Food or PPI can lead to an increased exposure to C. diff spores. It changes the pH by PPI. Then we can have the small intestine, can be where the spore germination occurs. As we have age and antibiotics too, this also can affect in the colon what we see happening there. The bile acids can activate the C. diff toxin A receptor. The C. diff proliferates and produces the toxins, and then that leads to this barrier dysfunction and diarrhea. Okay, so factors that resist pathogen infection include commensal colonic bacteria, so the good stuff that should be there, obtain nutrients and secrete inhibiting factors that reduce the growth of the newly arrived bacteria, so our gut microbiome can heal itself. The commensal bacteria that produces bacteriocins, microbial produced toxins to other bacterial species. Bile acid metabolism impedes C. diff spore formation or growth. And then we have our own IgA and IgG, which works against toxin A, so it would reduce its toxicity. But we have factors that will promote infection. So 1, antibiotic treatment. 2, PPIs that alter the gastric acid secretion. If we're in a hospital or nursing home environment, the older we are, older adults are more likely to be colonized by C. diff. And when they do get C. diff, they get sicker. And then we can also get C. diff ingested from contaminated food or by touching spores and spreading spores. Your book talks about this, that there are 3 phases of the C. diff diarrhea. The first process is the hallmark of the antibiotic-associated diarrhea in general. That's the disruption of the normal protective microbiota in a given individual. This function has been termed colonization resistance, and it is lost as a direct consequence of antibiotic use. All antibiotics can cause it, but the greatest association for CDI is amongst 3rd and 4th generation cephalosporins, fluoroquinolones, carbapenems, and clindamycin. So if someone were to ask you what are the most popular antibiotics that cause C. diff the most, 3rd and 4th generation cephalosporins, fluoroquinolones, carbapenems, and clindamycin. The host acquisition of C. diff is likely to occur through ingestion of spores through the fecal-oral route or touching a contaminated surface. During environmental stress, the anaerobe transitions to its spore form. In preparation, the cell divides into smaller components. The forespore then develops the spore in a larger component, the mother cell, which prepares for dormancy. The spore is encased in 3 protective and specialized layers, for which mutations in specific proteins has been shown to affect virulence. It's robust, and this form is stable to oxygen stress, and it resists the traditional killing methods such as heat and alcohol-based sanitizers. So the spores will live on environmental surfaces for a long time. Once you ingest it as the host, it'll disrupt the flora, and the C. diff can successfully colonize the large intestine where it thrives to the gut conditions. Intestinal acids promote germination. The anoxic environment supports growth and replication. And this process is thought to involve more than 500 genes. Once the C. diff pathogen is established, it begins to produce the toxins TCDA and TCDB, toxins A, toxins B, and they wreak havoc on our mucosal epithelial cells. These toxins are taken up by the cells through the receptor-mediated endocytosis. Following cleavage, the active subunit is then transferred to the host cell cytosol, where it glycosylates cytoskeletal regulatory proteins called guanosine triphosphatases. This action effectively disrupts the cytoskeleton, causing dissociation of those tight junctions between the cells and increased cell permeability, ultimately leading to apoptosis and cell death. We are so smart now because we now understand what endocytosis means and what we're talking about when we disrupt the cytoskeleton, right? We can understand better what we're talking about and how this pathogen works. The final phase of the C. diff pathogenesis involves the host response to the infection. Damage to our mucosal epithelium and then the subsequent translocation of our gut bacteria into deeper tissues, this initiates a rapid and profound host immune response. The release of our cytokines and chemokines then recruits our innate and adaptive immune cells. Neutrophils are of importance in the early host defense and bacterial killing. Although that response is necessary for infection control, the inflammation further adds to epithelial damage. The diarrhea burden of your C. diff has been correlated with the degree of intestinal inflammation and not the true pathogen burden. So if you get rip-roaring diarrhea, it doesn't mean you got a whole bunch of spores necessarily. The really crappy thing about C. diff that you're going to find in clinical practice is that recurrence is common, and it can come back within 1 to 3 weeks after you complete your treatment. In fact, 25% of patients after their initial episode, they get a recurrence and then get subsequent episodes. A lot of things go into those factors, but you can have resistance and recurrence. Some of the treatments that we have depend on whether it's your initial or recurrent state, but we can have oral or rectal vancomycin, oral fidaxomicin, we can have IV metronidazole, we can have a fecal transplant, and now we have the bezlotoxumab monoclonal antibody that we've been finding great success for treatment. C. diff is tough. It's now really tough to get rid of. It's hard in the hospital. Lots of healthcare dollars are spent towards preventing and treating C. diff. All right, next one we're going to move on to then is Borrelia burgdorferi. This is good old-fashioned Lyme disease. I've added your osmosis link here. I would stop and listen to that first. It's a great illustration and recap of everything we need to know about it in the book. Your book goes through the life cycle of the Lyme disease, and it's a complex 2-year life cycle. It's shown as figure 1.4. This is a very complex situation where we start with the eggs that go to larva, and then we get to the nymph stage, and then summer and fall comes around and we get to the adult tick, and then they come and, they lay eggs, and it kind of goes on and on. What I do want to make sure we understand is Lyme disease is spirochetes that can live in ticks, mice, deer, and humans. It's typically spread by ticks at the time of their blood meals, which is 3 times in their lifespan. Once a human is infected, the bacteria can migrate to our joints, our heart, and our brain. We need an enzyme immunoassay to identify it, and then the Western blot test if indicated. For the rest of your life, remember Lyme disease and Western blot. The lack of early symptoms may allow the development of the later phase with more extensive bacterial invasion and more severe symptoms. It's a bummer of a thing to find out that they have it, and it stinks that we often don't catch it very early. Prompt antibacterial treatment provides complete pathogen eradication. I'm going to let you guys read it. This one's much shorter, and the video does a perfect job of explaining these things. The next is our good old influenza. All right, I've added the osmosis link up here, so I would stop where you are and then go listen to the osmosis. They do a fantastic job with this one. A couple of things that your book wants us to know. Influenza A is the most common. In the video, too, they talked about the enveloped RNA virus and the variable hemagglutinin neuroamidase composition, the HN system. Of course, we know we've had severe epidemics and pandemics. The hard part about it is that the vaccine that we have must be decided before the season starts. We have to do our best to match with the actual annual strains. And the genes for viral proteins mutate rapidly, changing the antigenic targets. Host cell death and sloughing from our airways will contribute to our cough and many of our other symptoms. It does have the potential to progress to a viral or bacterial pneumonia. This is a nice image for us here that talks about that neuraminidase assists with the viral exit and cell lysis. We watched that video a little earlier about the flu as a virus. And then this one here again is a nice image of the influenza virus life cycle. And you can rewatch that previous YouTube video that we watched on the influenza from earlier in the chapter 5 too, if you'd like the refresher. Next one they talk a lot about in the book is the HIV, which is our human immunodeficiency virus. It's a syndrome it's a virus that could lead to the syndrome of AIDS, which is used to be life-threatening, and now we've come so far in treatment of the human immunodeficiency virus. I've added the link from Osmosis, and they do a phenomenal job explaining this. Remember that it's important we understand the steps of the HIV life cycle. That's spoken about quite a bit in your book as well. And this is the image that we have here. Again, you don't have to memorize this by rote memory, but you have to understand it and be able to refer back to it in your notes so that you can answer your test questions regarding it. We have the HIV progression if it's not treated. Very important concept to understand as well. The other thing I want you to make sure you're comfortable with hearing and reading and refreshing is that we have the box 5.7, which lists the AIDS defining conditions, which is very important to be able to refer back to. They do talk about, I've skipped, there we go, malaria. I've added your osmosis here. I would stop where you're at and listen to that for sure and come back here. They do a fantastic job of explaining the protozoal parasites of the 5 pathogen Plasmodium species, much better than I can ever do. Make sure you review the steps in malarial infection and the Plasmodium life cycle, which is outlined in this image here. The mosquito takes the blood meal, ingests the gametocytes, and the sexual reproduction occurs, and you get the production of the sporocytes. When the mosquito bites the human and you deliver the sporocytes, they will travel to the liver. Remember here that that's with the asexual reproduction of the schizonths. And then we get the merozoites, which exit the liver and enter the red blood cells to multiply, and they'll eventually release, and then you get the symptoms. All right, when it talks about pediatric considerations, I do think even though we're adult practitioners, it's important to understand this because you do care for down to the age of 13, so we kind of cross into the upper limit of pediatrics. These are some of those components of things to remember. Your book talks about COVID-19, and there is a brief section in that as well. When we talk about the gerontological considerations, they bring those here. They talk about a couple of different things. So when we're talking about the geriatric considerations in infectious disease, the real big one I want you to understand is that the infectious disease processes for older adults is different. Oftentimes, as we age, we are more vulnerable to infection. We tend to have waning immunity as we get older. Most people that live into the 6th, 7th, 8th, 9th decade of life have comorbidities. They'll end up, as we advance in our age, with suboptimal nutritional status. We then are putting people in long-term care facilities, and we're exposing people to other pathogens there. And manifestations of infections will change with age. Our baseline body temperature is lower. So if we're only going to elevate by 2 degrees, then is that enough to get a fever by our technical terms? and the fever response then is also blunted. Perceptions of visceral discomfort, perceptions of shortness of breath, and just even with things like dementia, our ability to recognize and report symptoms is often reduced. In 1991, there was that conference that was convened to begin to standardize criteria for surveillance of infections in long-term care facilities. And then in 2012, covering the same group of infection sites, but giving greater detail about the infection-associated alterations in temperature. We tend to not get white blood cell count activation as high. We will see more things like subtle or acute changes in mental status, and they get weak. Okay. When we go into some of the specific diseases, pneumonia is a very, very common one in elderly adults age 65 and older, and it's the third most common hospitalization diagnosis. Because of that, our current guidelines recommend that adults 65 and older receive the pneumococcal and the influenza vaccines. As you age, pneumonia has a higher risk of morbidity and mortality. We again know that because of our impaired immune responses and other physiologic changes that are occurring with our aging, we are a more vulnerable population. It's really important to have fast diagnosis and treatment. So we do have some of these things like the pneumonia severity index and the curve 65, which are prognostic indicators. When people have other factors such as their frailty, or they aren't good at swallowing, or they have a sedentary lifestyle, XYZ, these are all things that'll play into how sick they will get. The rate of hospitalization in older adults with pneumonia is twice that of MI and stroke. The mortality rates and 30-day readmission in older adults with pneumonia is also greater when compared to older adults with stroke. So it's a common disease, but it carries a bunch of morbidity and mortality. So in the older adult, the manifestations may occur and be more subtle. You may not have a cough, you may not have a high fever, and you may not even have an elevated white count. You may just have some altered mental status. They've been falling, they're not eating as well, now they're incontinent, they just haven't been getting out of bed. Those are the only things, and then you check for it, and sure enough, they have a pneumonia. We typically can diagnose it based then off of x-rays that we see the opacities, but at times, chest x-rays may not even indicate it yet in early pneumonia for older adults. Oftentimes they're dehydrated, and you need to have the hydration to actually form the opacity on the x-ray. And then again, the white blood cell count or CRP or procalcitonin, all of those aren't always as specific in the older adults. You have to be careful when you're relying on things like the CRP, because those are tests measuring inflammatory responses, and that can be misleading based upon our age. It's really useful to have blood cultures, gram stains, sputum cultures, or our urine check for the presence of pneumococcal Legionella antigens. However, the other hard thing is, in half of patients, we can't identify the causative organism. Things to remember. We may not have the causative organisms, but let's talk about the ones that are very causative. The typical common pathogens. Number 1, strep pneumoniae. Number 2, Haemophilus influenzae. Then we go into our atypicals like Legionella, Mycoplasma, and Chlamydophila. Strep pneumoniae and H. flu are the common two ones that we see the most. Respiratory compromise in pneumonia is often due to inflammatory response that promotes fluid entry into the alveoli, which then limits the gas exchange, and that's exacerbated when a viral or bacterial co-infection occur, and you enhance that inflammatory response. Next, we talk about urinary tract infections. It is the most common, I swear to you, thing I treat in my practice and in my career. I've treated so many gerontologic UTIs. They're very common, but they can be very, very dangerous. A lot of reasons for this. One, they're really hard to diagnose. Asymptomatic bacteria rates are insane. So you have to put the whole clinical picture together. If you took a bunch of 90-year-old men and women and you went and randomly got a bunch of urine samples and sent them for culture, you're going to have bacteria. Colonization exists, especially as you advance in age. So you have to confirm the actual diagnosis before you're going to treat. Remember, we're in the antibiotic stewardship era, and we don't want to get antibiotic resistant bacteria, and we don't want to have the complications that can occur with any antibiotic. So you have to pay very close attention to that. The risk factors for UTI are catheters and incontinence. Remember, we have other changes. So in older women, the changes in the vaginal flora and the vaginal pH create a more conducive environment to UTI. And in men, UTI becomes more common because they have the hypertrophy of their prostate gland, and that promotes retention of urine in the bladder, and the urine sits there and it becomes infected. Next, they talk about the varicella-zoster virus reactivation, so we have to think about the vaccine. Read through that paragraph. HIV is still popular as a diagnosis, and it can happen in older adults just as much as younger adults. And then again, the COVID-19 section as well. They have two great case studies that I really strongly encourage you to review and kind of look through and think on. These are great examples. It's beginning to show you, especially the bridge to clinical practice, is beginning to show you and prepare you to continue to build on to this information we're gaining, because then when we go to pharmacology, we're going to take what we're learning in patho and add the layer of pharm. And then when you get into assessment, you're going to add the layer of the physical assessment in the labs and the diagnostics. And then all those layers come together with critical thinking to form the diagnosis. So this is exposing you to the next kind of layers you're going to be prepared to see as you advance through the program. Those are really good examples. I think if you have to review a chapter like right before a test, going back through the key points at the end of the chapter, I think is great. It really is a summary of everything we've studied now in chapter 5. Please reach out if you have any questions or concerns. Thanks for listening.